Alrighty, good morning or afternoon out there to everyone. Thank you for joining us for today's medication-assisted treatment echo clinic. So great to see so many familiar faces, as well as I think a number of new folks joining us today as well. So introductions myself, I'm Troy Jorgensen. I'm the program manager here for Project Echo Nevada. Today we're going to have Dr. Farzad Kamyar speaking for us from the High Risk Pregnancy Center in Las Vegas, Nevada. But we'll go around the group here and have you all introduce yourselves. So Dr. Kamyar, you want to start us off?
Yeah, sounds good. So Farzad Kamyar here, psychiatrist and MAT provider, working as the director of collaborative care at High Risk Pregnancy Center, where we provide maternal fetal medicine / perinatology services to Las Vegas, and also there's an office in Reno. But we have a program known as the MOTHER program. It's an acronym. It stands for Maternal Opioid Treatment, Health Education, and Recovery. That program is specifically for folks in Las Vegas, and it's basically, it provides medication-assisted treatment primarily using buprenorphine for pregnant women.
Thanks. And then next we'll go to Mary. Do we have a microphone for you today, Mary? I can kind of hear some background noise there, but yeah, I can't hear your voice. Are you called in?
No.
No? Okay. Oh, I can hear you actually.
You can? Oh, okay. Hi. Mary Wozniak with Unity Healthcare.
Thanks, Mary. Next is Michelle, but Michelle, it doesn't look like you've joined the audio with us yet today. So just make sure to click the little microphone icon in the lower left corner, and we should be able to hear you. Same with Matt Hamilton. It looks like we don't have a microphone for you either. So if either of you want to write in through the chat box and let us know who you are and where you work, that would be fantastic. So Emily Zucker.
Hi, everybody. Emily Zucker. I'm a family doctor through Unity in Washington, D.C. I've been doing prescribing Suboxone for about 6 months now.
Thanks. Good to have you back with us today. Next, so screen name is XU5161. Go ahead, we can hear you. Could you introduce yourself?
Hi, you can hear me now?
Yep, go ahead.
Okay, hi. Samantha Gar. I'm a nurse practitioner in Las Vegas, and I'm just starting the MAP training through ANCC. So I just wanted to listen in.
Wonderful. Thanks, Samantha. Good to have you today.
Thank you.
Emily Ramsher. Oh, go ahead, Emily.
Hi, Emily Ramsher, family nurse practitioner, Unity Healthcare in Washington, D.C.
Thanks, Emily. Nima Alenjad from the addiction psychiatrist at the Reno VA. Thanks, Nima, for writing in. Michelle from CASAT. Thank you. Linda Christensen is next. Linda, are you there? Do we have audio for you today? Okay, maybe no microphone for Linda, so if you want to just write in. Carolyn Summer, go ahead.
Hi, yes, I'm a MAT provider with Unity Healthcare in Washington, D.C.
Thanks, Carolyn. Good to have you back. Michelle Stout.
Michelle Stout. I oversee case management and social work at Providence Kodiak Island Medical Center in Kodiak, Alaska.
Thanks, Michelle. So great to have you back. Echo, is that you from Hopes?
Yes, it is. I'm Echo Troop, licensed clinical social worker in the MAP program at Hopes.
And part of our panelists here for the MAT Echo Clinic. Thanks, Echo. Good to have you. Lauren and is it Lauren and Krista from Centers for Behavioral Health?
Hi, everyone. Can you hear me?
Yep.
Okay, perfect. So Lauren had to step out for a second, but I'm Krista. I'm the IOTRC director for Center for Behavioral Health, and Lauren is our city director in Las Vegas.
Thanks so much. Great to have you. Nikia White, are you there?
I'm here. Good afternoon, everyone. I'm a licensed clinical social worker at Unity Healthcare in Washington, D.C. with the MAT program.
Thanks. So great to have you back with us today. Allison Mullen. Allison, do we have audio for you today? Okay, maybe no microphone there, so you just want to write in through the chat. Jamie Millsap is next.
Hi, can you hear me?
Yep.
Jamie Millsap, program specialist with CASAT.
Thanks, Jamie.
In
Good
Las
to have
Vegas.
you. Dan David and your group down there, go ahead.
Hi, we're here.
Who all's there with you today?
So this is Arlene Brown, Recovery Support Navigator. Hallie should be, Vickers RN should be joining us shortly, and Linda Christensen, Licensed Clinical Social Worker.
Excellent, thank you. So great to have you all back today.
Yeah, good to see you.
And then we have a phone number that's called in, a 719 area code. Could you introduce yourself?
This is Michelle with CASAT. Thanks.
Oh, thank you. And then I think, is it Grace Johnson? Did you join us? Oh, it doesn't look like we have a microphone for you, Grace. So then it looks like Matt Hamilton, did you join the audio? Can you introduce yourself? Matt, can you hear us? Okay, maybe some issues there. So we'll open it up right now. Does anybody have any, okay, Matt wrote in, Lored Health Center from Delaware. Thanks, Matt, great to have you. So does anybody have any specific patient cases that they want to bring up before we get going, or any general questions for Dr. Kamyar? We also have Echo joining us as well. So any specific patient questions or anything along those lines, feel free to unmute yourself with the microphone icon in the lower left corner of the Zoom window, *6 if you're joined by phone, or you can also write in just using that chat box. Okay, but we're here throughout the presentation, so if something comes to mind, feel free to chime in by unmuting yourself or through the chat box. So we'll get going here with the talk from Dr. Kamyar.
All right, good afternoon, everyone. So I'll just kind of reiterate what Troy had said. Totally want this to be an open discussion. This is a pretty broad topic. And so I've tried to sort of distill this down as much as possible to its, sort of foundational basic building blocks so that you can kind of walk away with the, the basics of how to treat, I guess, basically pregnant women who might have some sort of opioid use disorder or some issue going on with opioids. So at any time, feel free to either unmute the microphone, ask a question, make a comment, use the chat box, whatever. I won't be offended if you interrupt or anything like that. So we'll get started here. So basically, opioid use disorder / MAT in pregnancy. Just a little bit of an overview, just in case some of us aren't familiar with what some of the topics of discussion are. We'll go a little bit into what opioid use disorder is, what medication-assisted treatment is, what neonatal abstinence syndrome is, and then obstetric care for women with OUD. So starting off with OUD, basically opioid use disorder in pregnancy. I'd like one of the take-home points for everyone in the talk to be that addiction or substance use disorders, which OUD is a part of, is a primary chronic disease. That's the short and sweet of it, basically the ASAM definition. And so we should be approaching it and treating it similar to we do with diabetes and hypertension. So anytime that I'm looking at a case, I'm looking at a patient, I'm thinking about treatments, I always sort of take a step back and say, is this how I would look to treat someone who has diabetes, or approach them if they had diabetes, speak to them if they had diabetes? And sometimes if we sort of take a step back and reframe addiction and OUD or substance use disorders and analogize it to diabetes, that can sort of help settle some of our own, anxieties about treating this patient population, or some of our biases of treating this patient population. So since it's a chronic disease, it's not a moral weakness or not a failure. Like other diseases, it often involves cycles of relapse and remissions. So we should be expecting these. These are sort of more so the rules as opposed to the exceptions. Where I see this oftentimes popping up is you will have patients who are in treatment and will do well for a certain chunk of time, and then something might happen, whether it's a life stressor, a change in their behavioral health status, or whatever, and they have a relapse or a return to substance use, and then whatever provider or whatever sort of treatment program they're in might kind of give them, I don't want to say give them the boot, but essentially that's what sort of happens. They sort of terminate treatments. And so that's oftentimes a really harsh way to go about things because, again, if we take a step back and sort of reframe it, so we have a diabetic patient who is on metformin and is on insulin and has relatively good control over their diabetes, and then has a donut, a slice of pizza, and a bag of Doritos. And they go see their PCP, and the PCP says, oh, well, you've had a relapse, so I'm going to no longer have you as a patient. Go find your metformin and your insulin from somewhere else. And that's almost the equivalent of what happens to someone who is getting treatment from whether it's an MAT provider, a residential program, whatever it is for an addiction or a use disorder. And then OUD in pregnant postpartum women has increased over the past decade, like the rest of the nation, with all the rest of the numbers that we've seen. And some of the numbers are staggering. I don't think I've listed them here specifically, but we can get into some of those. So as we can see, these numbers are, I think, several years old from when they were published. And then that was looking at data that was several years older than that. So if we look back this is probably looking back into, like, let's say the mid-decade. So let's say 14 and 15 or so. And we know that the numbers increased from 15, 16, and 17. But opioid use during pregnancy, so the Medicaid population, which does make up a significant population of pregnancy, coverage is significant. There was a recent study that was published out of Utah. The next, it's in a couple slides, where the numbers are even more significant than this. So for example, the average US Medicaid population is over 20%, but in Utah, for example, they were over 40% of their Medicaid patients were prescribed opioids. So the numbers can get, can kind of skew, or let's say, verge from these averages based on what states you're in, whether your state is highly affected by the opioid sort of crisis or epidemic that we have going on. But as you can see clearly here in the US, it's significant versus other countries. It's also causing a problem when it comes to pregnancy and maternal deaths. So if you've heard in the news recently, all this sort of, these headlines about maternal deaths are on the rise. Oh my gosh, we're in the United States, and how is it that, this first world country where we're like the beacon of hope for everything and the standard of care for healthcare and technology, why is it that our maternal deaths are increasing where in the rest of the world they're sort of decreasing or are stable? So here you can see there's a list of some states, and they make up a pretty significant chunk of the maternal deaths are drug related. And any pregnancy or maternal death is sort of defined as when a patient or a woman is pregnant in the year postpartum. This slide is from that most recent sort of the Utah study that came out, and that showed that in Utah, the maternal deaths associated with drugs, so drug-related deaths, were the #1 cause of death for pregnancy-related deaths. And that outweighed or outnumbered the next two combined, which I believe were thromboembolism and motor vehicle accidents. And then it went down the list from there, things like hypertension, infection, and whatnot, including suicide and like homicide. But what's significant, I think, from this slide, it shows that of the sort of deaths, you can see the significant spike in that 43 to 365 days postpartum period. And generally speaking, we think of that as they've now sort of that postpartum woman has had her sort of postpartum OB visits, and then possibly that Medicaid, pregnancy-related Medicaid coverage is ending. So as OUD has increased, we've also seen an increase in NAS. NAS is neonatal abstinence syndrome. The more specific one that's related to opioid withdrawal syndrome is called NOWS, neonatal opioid withdrawal syndrome, and we'll get to that in a bit. But as you can see, there's a rise. It's gone from 2000 to 2012. Again, these are older numbers, so the numbers have just increased since then. And associated hospital stays are significantly higher when you have NAS compared to when you don't have NAS for the neonates, and then the costs as well. And there's been a couple papers since that have said that the cost of $66,700 might be a little underestimated, and they've quoted numbers that have been in the mid 100s, so about $150,000 or so. Okay, so we can move on to medication-assisted treatment. Sorry to those of you who are well-versed in what medication-assisted treatment is, but it's basically the use of FDA-approved medications in combination with counseling and behavioral therapies to provide this quote-unquote whole patient approach to the treatment of substance use disorders. And this is basically from the SAMHSA website, and they say for the treatment of substance use disorders, but medication-assisted treatment in fact happens across a broad range of other disorders as well. For example, diabetes and hypertension. Medication-assisted treatment is when you provide things like counseling, behavioral therapies, and medications like a hydrochlorothiazide or metformin for someone that has diabetes or hypertension. So it's not this sort of scary term that only applies to people with addiction or a use disorder or substance use disorder. I think generally speaking, that's kind of how we think of it, and that providers might sort of have this, I don't know what MAT is, I'm very unfamiliar with it, but probably not realizing that they generally do it on a day-to-day basis. When it comes to pregnancy, it's the standard of care. And so it's recommended by all sort of national associations, and this is spanning, ACOG, SMFM, ASAM, SAMHSA, the World Health Organization. You can pretty much go to any sort of organization, and it's going to be noted as the standard of care. And one of the good things about pregnancy and MAT is that it's sort of this window of opportunity for the treatment of chronic diseases. Again, when we think outside of use disorders, if you're talking to, let's say, whether it's an OB-GYN provider or whatnot, and you say, well, someone has, maybe gestational or pre-diabetes or diabetes, and they say, well, pregnancy is a great time to catch these sort of chronic diseases, right? Whether it's autoimmune, diabetes, and whatnot. Again, same thing here for use disorders. And you'll find that oftentimes, of course, this is not 100% of the cases, but more, I would say more so than not, the motivation behind women wanting to seek treatment and engage in treatment will be higher during pregnancy than they would otherwise have outside of that pregnancy timeframe. So it's a good time to catch the patients and hopefully get them into treatment. And when I use the word catch, I didn't mean like, catch them red-handed by performing a urine drug screen. And that's not at all what I mean. I mean to basically, screen them and get them into treatment. And the whole goal behind basically treatment is to reduce maternal, obstetric, fetal, and infant morbidity and mortality. And there's a direct correlation. I mean, there's basically no doubt about it. There's no questions here that if you can engage them and get them into treatments or engage them in any way more so than not. So we'll call treatment sort of anything that you can do, whether it's just seeing them on a consistent basis and having, brief interventions with them, which are sort of talk therapy related, and asking them to question their use and the motivations behind them, versus getting them into a full-blown program where they're now on buprenorphine. versus the alternative, which is, let's say they're using heroin illicitly, getting them into treatment it's almost black and white in this instance. And I a lot of times don't like to think in black and white thinking, but when it comes to this, all the sort of evidence out there shows that having patients in treatment, the benefits far outweigh the risks of not. So continuing on, Matt, so some options. Generally speaking, when we think of outside pregnancy, there are 3 FDA-approved medications: naltrexone, methadone, and buprenorphine. Naltrexone in this population is not extensively studied. However, data is probably being compiled now and will be coming out for that, which is awesome, because from what I've seen, the results are really good. And then methadone, the longest tried and true. I think the most evidence is out there for methadone, but buprenorphine is vastly catching up with the data showing, I think across the board, that during pregnancy, methadone is probably the preferred agent over methadone, speaking specifically during pregnancy. And that's why I wrote, that's the preferred agent, but that in some cases methadone may be used. And the sort of the data behind this is mostly surrounding the status of the fetus/neonates when we're comparing buprenorphine to methadone, where there's less incidence of here we say neonatal opioid withdrawal syndrome, less incidence of it, shorter duration of the actual NOWS, less treatment requirement, and shorter hospital stays. One of the seminal sort of papers that came out on this is Jones back in New England Journal 2010. So here you can see on the graphs where we have got methadone versus buprenorphine, total dose of morphine required, mean hospital stays in days, and then the mean duration of the NAS treatments. And there's been subsequent studies after this that have showed sort of this, showed similar outcomes and then additional sort of parameters. So some of the pros of buprenorphine versus methadone: there's the lower risk of overdose. So going to some of the specifics about buprenorphine is a partial agonist, partial antagonist. So it's like a halfway almost medicine, which means that there's a ceiling effect. If you were to take, let's say, 2, 4, 8, 12, 16 milligrams, 24 milligrams, across that range, you start to get a dose response. But then above 24 milligrams, there starts to sort of be a taper, this ceiling effect, where we don't generally see any improvement in benefit regarding the medication. But what that also means is we don't see any, some of the drawbacks with our other classic opioids at the higher doses, where you start to see respiratory suppression or those other issues that lead to sort of these overdoses that we think about. Fewer drug interactions, where methadone, you need to be in sort of a federally licensed OTP institution or clinic. Buprenorphine can be provided by any provider that is waivered through the sort of the DEA or CSAT. Dosing of buprenorphine is generally thought of to be similar in non-pregnant women. So what that means is a lot of times you will find that some medications during pregnancy, the dosages get increased because of increased blood volume or whatnot during pregnancy. But buprenorphine, generally, we find that once you find this sort of stabilized dose, most patients generally tend to do well in that dose throughout the remainder of their pregnancy. Fewer side effects, like we mentioned, sort of those less adverse cardiovascular side effects, and I would say almost no cardiovascular side effects. And then, like mentioned before, sort of that in-utero exposure for methadone comparing to buprenorphine. When the studies were put out there looking at buprenorphine versus methadone, and just methadone in general, there's a sort of association with methadone being known to have higher incidence of preterm birth, lower birth weight, lower head circumference, and then, of course, the higher severity of neonatal withdrawal. So some of the cons of buprenorphine versus methadone, and I would say that I mean, you can look at the list that goes down. We won't go through all of them, but I left a lot of these up here, and some of them aren't as relevant now as they were before. The evidence base regarding buprenorphine is kind of consistently changing as more studies are coming out. I would say probably on an annual basis, we're getting more evidence that can change the way that we practice when it comes to buprenorphine in pregnancy. And we'll go into a little bit of that in a little bit. But for example, like lack of long-term neurodevelopmental outcome data. There's limited data about pregnancy outcomes after first trimester exposure. I would say some of this stuff is starting to fall out because we're starting to get data that's showing that, for example, pregnancy outcomes after the first trimester exposure are really good. But some of the other stuff hasn't changed. Like, for example, it is more expensive than methadone, especially if insurance doesn't cover it. However, I mean, especially in the Medicaid population, we are finding that Medicaid does cover it, and mostly it's being covered fully without any deductibles. So this is one point that I wanted to put up because through my experience with buprenorphine, I have found, I'd say, a good chunk of time when someone has told me that buprenorphine has not worked for them, I will ask them how they administered the medication, and found out that they were never told or instructed on how to do it, whether it was the provider or the pharmacist. And so if you are planning on prescribing the medication, I highly recommend that you yourself go over this, because it's pretty easy actually. So you want to discuss and educate a patient on sublingual administration, and that's the key, is that it's sublingual, not swallowed, of course not injected. And the reason behind this is that buprenorphine gets extensively first-pass metabolized and has extremely poor bioavailability when they swallow it. So I tell patients point blank, whatever you swallow just will not work. And so on the very conservative side of things, I will show patients, I'll raise my own tongue, and then I will place, like, and then I'll, show them where to place the tablet or the film. And then I say conservatively, once you place the tablet or the film there, don't eat, drink, talk, spit, or smoke for about 30 minutes. For all intents and purposes, you could probably get away from anywhere from 5 to 10 minutes or so, 15 minutes on the high end, but I say 30 just to be safe. And of course, tell them to let it completely dissolve. So we've talked about that the dosing is similar. And there's a lot of talk out there that the initiation of or the induction of buprenorphine is more difficult than something like methadone, and that's one of the cons. And I would say, if I had to say yes or no on it, then I would say yes, it is more difficult to initiate someone on buprenorphine than it is on methadone. But that's relatively speaking. I would say overall, no, it's not difficult, because generally speaking, what we have patients do is we just say, don't use don't use on starting the day before you're going to come in for induction. And most patients are able to do that, because whether it's longer acting or shorter acting, across the board, whether it's pain pills, pain medications, or heroin, when the patient uses even up to about the night before they're coming in the next day for induction, when they show up the next morning, they are in enough withdrawal, so moderate amount of withdrawal, such that we can get them induced on buprenorphine. So it's more difficult than methadone, because methadone you can start right away. They can walk into your office and boom, you can administer methadone. However, overall, I would say no, it's not a difficult process. One of the good things, just because of that sort of dose response, so maintaining the dose intrapartum and postpartum, that's really important. We'll get to that as well. And encourage to breastfeed. There's a lot of misconceptions. We've heard it across the board. All derivatives of the different formulations of buprenorphine can and cannot breastfeed. So we've heard it all. encourage breastfeeding. Doesn't matter what formulation you're on, whether it's Subutex or Suboxone. Breastfeed, breastfeed, breastfeed if the mother is able to. And we can go a little bit into that. Is basically, you know, if you think of it as let's say worst case scenario, even though I think the data shows that it's a very small percent, right? I wrote here less than 1% of the doses in breast milk. If you think about it like we do in the adult person who's taking the medication, it's extensively first pass metabolized. So whatever baby is swallowing is getting chewed up anyway. So take that minuscule amount that they're getting, first pass metabolize that anyway. So they're basically getting nothing. So it's not that we're saying to encourage breastfeeding because that's going to provide buprenorphine to the neonate and then lessen their like neonatal abstinence withdrawal syndrome. That's not it. It's just that breastfeeding is generally thought of to be sort of better, and it encourages sort of skin-to-skin contact. These other sort of factors that do lessen sort of that withdrawal syndrome encourage bonding and whatnot. So,
Dr. Kim, if I could just pause you for just 1 second.
Absolutely.
If anybody has any questions out there right now, feel free to unmute yourself. Dr. Andracki, I see you joined us. Do you have any questions? No? Okay. Anybody else have a question? So question here, so sublingual is the best form of buprenorphine for pregnant women?
Versus what? What other form are we talking about? Oh, are we talking like the long-acting depots and whatnot? If that is it, then yes. I mean, so that's what I would say. Because I want to say there's no data. Well, let's just say there's limited data or no data on the other forms of buprenorphine now, the sort of the longer acting ones, or the depot formulations. So right now, yes, sublingual, whether it's the tablet or the films, basically. And when we're deciding on which one to prescribe, I think we'll get into this in a little bit. Subutex versus Suboxone. It's basically insurance. Insurance and coverage is what drives what we're going to put the patient on. So, you know, early on, I would just generally recommend more frequent visits. So weekly, and then kind of extending the visits as the patient is showing, you know, signs that they're doing better in their sobriety, or they're maintaining their sobriety, or areas of their life are sort of improving. Perform urine drug testing, and if you're going to perform that, there's no set standard on the frequency with which you're going to perform urine drug testing. But if you are going to perform it, make sure that you do test for buprenorphine, because there's a lot of tests out there that do not test for buprenorphine. If a patient does experience cravings, withdrawal syndromes, return to substance use, instead of sort of freaking out, I would just say start out with assessing their needs. What's the reasons? What was the motivations behind it? What happened socially? Stressors, triggers, and then stepwise approach it. Consider sort of increasing the frequency of their visits, the intensity of their treatments. So if they have any behavioral therapies or interventions going on, consider maybe going from every other week sessions to weekly sessions, and then consider increasing the dose, or maybe even split dosing. I will say we've had a fair number of patients who do better on split dosing than on single single daily dosing, for example, in the morning. Whether that's a psychological response or whatnot. I mean, the FDA label, and when you check like the websites and whatnot, for Subutex and Suboxone, they all state I think it's the duration of action is like 24 hours or something along those lines. But some patients will swear up and down that it only lasts a certain amount of time, 8 hours, 12 hours. So they'll be on BID dosing or TID dosing. That doesn't necessarily mean that I'll change the total daily dose, but I'll just sort of split the total daily dose. And I would say in general, consider capping the maximum dose at 24 milligrams. We have a fair number of patients that I would say probably have stabilized nicely on 16 milligrams. And then 24 as the upper end of the spectrum. That's kind of what all the guidelines and the FDA label and the guidance says is 24. There have been cases where we have gone, or I've gone to 32 milligrams, but not during pregnancy. But I would say don't shy away from it, just because that those are sort of the recommendations that are out there. You can legally prescribe up to 32, I believe. But I would say just have a good case for it, like the patient is showing a response to increased dosages of medication, and you're relatively certain that there's no diversion going on or whatnot. So buprenorphine versus Suboxone. Subutex is the mono product, and Suboxone is generally what we think of to be the combo product, which is the combination of buprenorphine and naloxone. This product was designed to basically reduce diversion and abuse. To get a little bit into it, basically naloxone it doesn't affect you, and it's not bioavailable if you administer it sublingually. However, if you bypass that by injecting it, then it is available. And naloxone that's Narcan, it's the antagonist. So you will basically immediately go into withdrawals, feel really crummy. And so that's why it was designed to sort of reduce this diversion / abuse, so that it has, less street value and whatnot. Pregnancy is a special time period. Pregnant women are a special population. So early on, a lot of the evidence was only around buprenorphine, the mono product. And that was because, generally speaking, we like to avoid exposing the fetus to anything, right? To any sort of substances. And so it was thought that maybe naloxone might be teratogenic based on some, I think it was animal studies. And so the recommendation was during pregnancy and in the postpartum period, breastfeeding, just use the mono product. But then data started coming out, the studies started to be published, where pregnant patients that were primarily placed on Suboxone, the comparisons were made, and there was no increase in birth defects, fetal anomalies, fetal deaths, all that kind of good stuff. And so it's falling more into favor, I would say. And people are not as scared as using Suboxone, which is the combo product, during pregnancy. And because of this, because of the fact that the data now supports it, and that there's less risk of diversion with the combo product, I think the use of Suboxone will expand, with the caveat that insurance covers it. Again, that's what we use to drive what we place our patients on. So first, it's like, is it a commercial patient, commercial insurance patient, or is it a Medicaid patient? And we kind of take it from there. But at minimum, I would say no need to sort of preferentially switch a patient that's already on one medication for the other. For example, you have a woman a woman who's in treatment, she becomes pregnant, she was on Suboxone, just continue her on Suboxone, no need to switch over to Subutex. So I put this, let me go to the next slide. Yeah, okay. So I put this study in there because this is a relatively recent study. I want to say it's less than a year old now, coming out of Tennessee. And generally speaking, we consider MAT during pregnancy to be the gold standard for opioid use disorder. And a lot of the guidelines and recommendations out there would always state, do not sort of, medically withdraw patients or taper them during pregnancy. And because the risk outweighed the benefits, because of the risk of return to substance use, relapse, overdose, all those sorts of things, exposure to infectious diseases. But Craig Towers and co out of Tennessee, they did this novel study where they took 4 groups of patients, and they basically did, it says detox, but it was basically, a medically supervised withdrawal or taper, should I say. And what they found was, for those that successfully tapered, but remained in behavioral health, whether it's follow-ups and therapy, sort of just remained engaged with behavioral health, the rates of NAS were significantly reduced. And so that's significant because it's, lessening sort of exposure to the neonate in utero to opioids. It's lessening the rates of NAS. And the rates of relapse are pretty phenomenal for this patient population when we look at, those that are engaged in treatment or those that are, engaged in other forms of therapies or treatments. So what I think that this is doing is that, and the guidelines and recommendations have not caught up yet. The most recent ones have caught up to this in no longer condemning withdrawal during pregnancy. They now say that you can consider it for the right patient. And that is what I agree with as well. And I would say it basically takes a very special patient. So it's a super high functioning patient where the social supports are all there. They're really consistent with follow-up. I mean, everything else is sort of in place where you have like that inkling of this patient could do well if they were to slowly be tapered off their medication. But I like the fact that it removed this sort of condemnation that was going on that said, absolutely not, you do not wean patients during pregnancy. And I would say there was a lot of fear also before that, that, this detox or this withdrawal during pregnancy is going to lead to fetal deaths. And, the mom's going to go into early labor and, it's going to be a really bad outcome. That I would say the caveat there is that I don't want I don't want detox and medically assisted withdrawal / taper to be confused with just full blown sort of cold turkey withdrawal. I still think that there is a risk for that situation, but it's the monitored kind or the tapered kind that doesn't need to be, the fears were sort of overstated. So, it was a couple case reports back in the 70s where there was a couple bad outcomes, fetal demise. But since that time, I think a handful of studies and 700 cases of opioid detoxification during pregnancy without a single fetal demise related to the process. So basically, what does that mean? I would say it means that you can offer patients continued treatments, which would be the sort of the global recommendation, or for that very specific patient that you think would do well and wouldn't have an immediate return to substance use because of so many different factors or environmental stressors or whatnot, you can sort of offer that as an option or offer taper as an option. And if you are going to pursue that, the first step is to actually put them on MAT. So like, for example, you put them on buprenorphine, you stabilize them, and then you wean them down. And again, highly motivated patients, access to behavioral health. And then, of course, yes, and then the absolute requirement for this is that behavioral health continues during and behavioral health continues afterward. Because if it does not continue afterward, then what they saw in that study was that the relapse rates were through the roof, right? It was basically like they had just gone through, a quick detox, and the return to substance use was in the high 70s. So a poor outcome if behavioral health is not a part of the continuing equation. Okay, so we'll move on to a little bit about neonatal abstinence syndrome, also known as NAS. So this is the signs and symptoms that occur when there's been a prenatal exposure to a substance, and that substance exposure gets interrupted at birth. And a lot of times we sort of use it, we sort of use NAS to also speak about the withdrawal that occurs when there's been exposure to opioids. And so most recently, the term neonatal opioid withdrawal syndrome has come into favor to clarify that we are talking about the withdrawal associated with opioids. And this is because there's NAS that's associated with other medications, for example, SSRIs or benzodiazepines. And so we want to be able to differentiate between the two. But NAS has been the term that's been used widely now for, I would say, many, many, many years. And it'll probably take a good bit for NOWS to sort of fall into favor. And NOWS can be made more sort of severe and increase the prevalence of, or the incidence of, if there's polysubstance use, tobacco use, and or the use of other illicit substances. So some recommendations out there for patients, if you're doing any sort of brief interventions, would be probably a number one thing would be to stop smoking. That's probably the single greatest thing that someone can do to sort of lessen the incidence that they're going to experience NAS if they're on something, if they're going to be on something anyway, or the severity of those symptoms. And some signs of NOWS are increased muscle tone, tremors or shaking, poor eating, vomiting, this trouble sleeping, yawning and sneezing. A lot of these symptoms are sort of echoing what adults go through when they're going through withdrawal from opioids, because that's basically what's happening. That's basically what the neonate or the baby is going through. In general, when you look at sort of the American Academy of Pediatrics and some of the guidelines that are out there, monitoring should last for at least 4 days. However, we found that this varies widely by institution. I can go into this in great detail. The folks at the Empowered program are highly versed at this because this is like their bread and butter. But there's a lot of factors that go into NICUs and the hospitals and the protocols they employ. But I can tell you that this is not being done universally. So for example, you will have hospitals that might only monitor for 2 days. The implications of this are that you might have, you likely have neonates or newborns going home who are then going to be experiencing NOWS at home under the care of a mom without appropriate provisions to take care of that baby, other than hopefully getting in to see a pediatrician. So hopefully we can get some standards in place that all hospitals will sort of stick to for monitoring. Really cool is that non-pharmacological care has been shown to lessen symptom severity. And so this is actually the first line treatment. Traditionally, we think of sort of morphine, so opioid replacement for the neonates. But these non-pharmacological interventions are awesome at reducing the symptoms or reducing the need to have any sort of intervention, whether that's morphine, or reducing the need for the neonate to go into the NICU. And they're all, I want to say, free, I think, if we look at them, and super easy to implement. Breastfeeding, rooming in, which basically means baby stays with mom, skin-to-skin contact as much as possible, holding and swaddling, and then a quiet room and environment with limited visitors. But of course, the parental or caregiver presence is encouraged. And if I could, I would have this available to every single patient. However, again, unfortunately, this varies widely by institutions. And so you will have some institutions that will say, oh, baby has been exposed to anything, or let's say baby has been exposed in utero to opioids. They are automatically going to go to the NICU. And so that makes a lot of this difficult, right? So that immediately eliminates rooming in. It cuts down on the amount of skin-to-skin contact, holding and swaddling, and then it cuts down drastically on quiet room and environment because it's the NICU. And then unfortunately, there's also a lot of misinformation out there on breastfeeding. You will find providers out there, and this is, let's say, even in the hospital setting, which is, labor and delivery or neonatologists, nursing staff. I mean, it's across the board that will say, no, absolutely not. You cannot breastfeed because you use something, or, oh my gosh, you're currently on, let's say, methadone or buprenorphine. No, you cannot breastfeed. And that's misinformation, unfortunately. Of note, there was let's say the community had been noticing that there was this sort of association with neonates that were experiencing NAS and having sort of decreased neonatal head circumference and childhood educational disability. And so there had been some studies out there, but they hadn't been able to sort of pinpoint it directly to any sort of exposure. But a couple recent papers were released earlier this year that showed that yes, basically they broke it down, and again, this is coming out of Tennessee, and why is so much stuff coming out of Tennessee? Because Tennessee is really cool in that So Knoxville heavy hit by opioids. So they're one of these centers where there's a lot of moms who've been affected or are affected by opioids. And then the medical center there at Tennessee, their OB and maternal fetal medicine departments, it's at an educational institution. So everyone's together, everyone's collaborating, and they've all got the databases to look at the data, to monitor the data. And then they follow these kiddos for many years afterwards because of the sort of the global Tennessee databases, which to my knowledge, we don't have here in Nevada, and we don't have coherence or consistency across even our hospitals. It's kind of like separate silos, all operate as silos. So they're able to put a lot of this data together. And what they found was if a neonate had NAS, it's had smaller head circumference, and the smaller head circumference was significant. It was 0.9 centimeters, so 9 millimeters, almost a centimeter. And in the OB pediatrics world, that is extreme. I'll just say that's extremely significant. That is extremely significant. And that, and across all the factors, I mean, they looked at all the factors and they controlled for a whole bunch of factors, including polysubstance exposures like marijuana, smoking, alcohol, stimulants, SSRIs, benzodiazepines. And the one that came across was opioid exposure, unfortunately. So opioid exposure. And then there was another study that they also put out, and that looked at childhood educational disability. Same thing. It was if the kiddo experienced NAS, then there was a higher likelihood that they would be referred to services. And this was kiddo that was experienced NAS, of course, as a newborn. And then now they're looking at them 3 to 8 years later. So now they're a 3-year-old or an 8-year-old. If there was a higher incidence that they would be referred for any sort of learning disability, and that they would receive services for any sort of learning disability. So some things to keep in mind when we're thinking about exposures and NAS or NOWS or whatnot, is that there is this this instance that, the neonate might have a smaller head circumference, and there might be educational disabilities or learning disabilities down the line.
So we did have a couple of questions come in. So the big study that you were referring to a few slides back, would you be willing to find the link to that and share that with everyone?
Yes, absolutely. I can send out the links to these. Yeah, absolutely. Yeah, okay. the three that I read. Yeah,
if
totally.
you send them to me, then I'll just share that with everyone at the next session.
Sure, will do.
And then question, what if the mom is on other substances like PCP or meth? Then what do you do with breastfeeding?
Okay. Yes. Okay. So if we go back, so breastfeeding, that's where the if not contraindicated. So good question. The contraindications are HIV, active like herpes lesions at the site, and then illicit substance use. And PCP and meth would count against illicit substance use. So if there's any of that going on, then that's when breastfeeding is contraindicated. But outside of that, it's encouraged.
Okay. And then are there any statistics on Bupe babies at age 3 and 8?
In regards to the educational disability?
Lauren or Krista, could you expand on that a little bit?
Yes, just to see if they do have any kind of educational disabilities or if they're thriving, because I don't know if there are stats or not with those, the moms who are on buprenorphine, and once they do give birth, do we have any statistics of those kids at ages 3 and 8 on how they're developing?
Yeah, so in that study, those moms that the moms that they included for the educational disability, they were not able to specify what the exposure was. I believe they weren't able to specify what the exposure was. They were just able to say they experienced NAS. So I don't know if we know that. What I can tell you is this, is that it's very specific to experiencing NAS, right? and that the incidence of buprenorphine is the lowest for experiencing NAS compared to illicitly using or methadone. So that's why it's the preferred agent during pregnancy. Methadone, some studies out there will show numbers as high as 80%, and that the severity is really bad. So like, you know, days in the hospital, amount of morphine required for the neonates is pretty intense. But for buprenorphine, it's a lower incidence. So let's say 80% of possibly 80% of kiddos who are exposed to methadone experience NAS. You might have somewhere between 30, 40, 50% of neonates or babies that were exposed to buprenorphine experience NAS. And of those that do, the severity is much less. Does that make sense?
Lauren or Krista, did that help answer your question?
Yeah, I would just kind of like to have some more data on that. So is there any way that you could send links to the studies and stats on those?
Yeah, sure. So I can send out the link to that. I mean, the Jones paper in 2010, New England Journal, is kind of what kicked off this whole buprenorphine versus methadone. I would say that's probably the seminal paper, because then they did the huge mother study that was associated with that showed, and then there's been several studies since that show the favorable effects of buprenorphine versus methadone.
Okay, so we can follow up with those resources and references at the next session. Dr. Cameron, you'll be joining us at that one, correct?
I believe so, yes.
Okay, July 10th would be the day for that one.
Okay.
So we'll follow up with those more next time. So we'll keep going here. Yeah, thanks for the questions, everyone. Feel free to continue to write those in through the chat or unmute yourselves.
Okay, so chugging along. So the next slides are basically going into obstetric care, and we'll kind of fly through these. This is mostly for those that are involved in any sort of obstetric care, your primary care providers, it could even be your first responders, those that are in labor and delivery, triage, emergency rooms, because you people are all seeing, these folks when they come in for one reason or another. I would say the most important thing is identification. So this is why there's a big push to perform SBIRT, SBIRT standing for screening, brief intervention, and then referral to treatment. And this is for every pregnant woman, and that this is the standard of care. So it's not like it's nice if you do this, you should do this. It's like, it's almost your duty to do this because it's the standard of care. Universal screening means universal, which means everyone. It means we don't base it on age, race, suspicion, physical appearance, or anything like that introduces a whole bunch of biases and ethical issues. And we perform it using validated tools such as the 4 or 5 Ps, NIDA Quick Screen, and the CRAFFT. And this universal biologic testing, which I would say is more prevalent. I would say universal questionnaires are much less prevalent, but universal biologic testing is much more prevalent. Unfortunately, the recommendation is to not perform universal biologic testing. So we need to change our sort of practice when it comes to this, because there's various shortcomings when it comes to like performing a urine drug screen. And that's why it's basically not the recommendation. But if you are going to perform it, it should only be performed with consent. That's another shortcoming because a lot of times it's being performed without consent. So here's the 3 tools. You can take a look at these. One of the simplest ones are these 4 Ps, 5 Ps. The Ps stand for, like past, partner, parents, peers, pregnancy. So is there any issues with drugs or alcohol during those timeframes or with those sort of people? So you want to also look for comorbid sort of psychiatric conditions, domestic partner, intimate partner violence, because that's huge within the community as well. Additional laboratory testing for sexually transmitted infections, TB, HIV, Hep C, check the Nevada PMP, discuss Narcan, offer a prescription. And then your consultations, so maternal fetal medicine, so high risk or perinatology, your social work, your case management, and then anything else that's appropriate, you know, like the behavioral health or infectious disease or cardiology. During their care, this is sort of getting to specifics, but growth scan at 28 weeks, antenatal testing at 32 weeks, delivery at 39 weeks. This is one of the studies that was out there previously. Opioid analgesics leading to some birth defects, and I want to say, I think this one specifically might have been methadone. Ventral septal defects, some heart stuff, some spine stuff, and some stomach stuff. Then intrapartum. So intrapartum is basically at time of delivery. You want to rescreen them on admission. You want to confirm their MAT medication and dose because you want to continue that through hospitalization. So this is really important because there's misinformation out there. I would say that the best strategy is to continue whatever they're on through their hospitalization. For better pain control, feel free to, and I would actually recommend to split their dose. So if they're on 16 milligrams, feel free to split it up into 8 milligrams in the morning, 8 milligrams at night, for example. As mentioned before, encourage the non-pharmacological interventions to reduce that, you know, the NAS, NOWS symptoms or incidents of. Get your consults again, the neonatology, maternal fetal medicine, anesthesiology, social work. One of the standards is to offer immediate placement of long-acting reversible contraception before discharge, if it's available. And the reasoning behind this is that it's somewhere about 80% of all pregnancies with those who have a use disorder are unplanned. And so one of the most stressful things and one of the most contributing factors to the high risk period, which is the year postpartum, is another unplanned pregnancy. So that's why this recommendation was made. And developing a plan of care using a multidisciplinary team approach prior to discharge. And for those of you that don't know what a plan of care is, this is something that came about from sort of CAPTA, which is the Child Abuse Prevention and Treatment Act, which was, I think, Obama era, and then CARA, which is Comprehensive Addiction Recovery Act, is Trump. During Trump's presidency, he kind of added on to CAPTA. And this is basically any healthcare provider that believes a neonate was exposed to substances in utero or is experiencing any sort of withdrawal symptoms needs a plan of care. And a plan of care is basically just to make sure that the kiddo and the caregiver / mom has all the resources that they need. It's not like a CPS thing. It's more so like a resources thing. But that's a requirement now. It's a requirement that they get this filled out and submitted prior to discharge from the hospital.
Question that came in: when would you determine if mom would benefit more from methadone than buprenorphine?
So the when would be, I would do that immediately, like immediately upon, like, let's say screening and you're talking about treatment options. I would default to buprenorphine, and then I would veer towards methadone if there are situations which would lend themselves to methadone. Like, for example, you feel like the mom would benefit from the structure of, let's say, daily dosing, for example, or they are currently on methadone. You know what I mean? They've been on methadone in the past and they had a really good treatment response to it, and they don't want to be on buprenorphine, you know. But if they're being screened and they're being identified, and you're now looking at a fork in the road, and you're saying, all right, I'm going to offer you the option of one versus the other, I would say in general, I would provide the buprenorphine option first, unless there's sort of quote unquote contraindications to it, reasons that you would feel that they wouldn't do well on buprenorphine. Okay, so we talked about the plan of care. So this is getting into real specifics, so we can kind of just glance over these. Interpartum pain control. Basically, you're going to continue the buprenorphine or the methadone dose that they're on, because if you withdraw those medications, you're going to find the patient's going to be at a baseline hyperanalgesic state, and you're going to be paying catch up to just even get to their baseline pain control. And then you're going to need to go above and beyond that. So that makes it very difficult. So just stay where they are, split to twice a day or 3 times a day dosing, and then start to use anything in addition to that. So some adjunctive things like ice packs, heat pads, local anesthetics. We highly recommend getting a spinal or an epidural. That's why anesthesia wants to get involved early when they come into the hospital. Schedule your Tylenol and ibuprofens. Use Toradol if it's not, ibuprofen is not tolerated. But if they need breakthroughs, especially for your C-sections, so your normal vaginal deliveries, generally your APAP or your Tylenol and your ibuprofens or your NSAIDs gets you there, in addition to their sort of MAT. But for C-sections, feel free, and it's encouraged actually, if they don't have adequate pain control, to step it up to like a PCA with high potency opioids like fentanyl or Dilaudid for like a day or 2 and scale it back from there, because short-term opioids are not associated with relapse, but inadequate pain control is more likely to cause relapse. So don't be afraid to adequately treat pain while these patients are in the hospital. And if you are going to be discharging them with narcotic prescriptions, think about keeping it less than 3 days, sort of that CDC recommendation. And then we'll touch on postpartum care, because this is one of the most important periods of the whole discussion that we've had, because it's the highest risk, the most deadly for women. If you remember looking back to some of the data that came out of Utah, but it's kind of across the board, like if you look at the states like Alaska and Texas and whatnot, high maternal mortality in that postpartum year. That's because there's a new baby in the picture, providers are falling off, insurance coverage is falling off, and so moms are sort of falling out of treatment. And so there's a return to substance use, tolerances are now gone, and it's leading to overdose and deaths. So in that postpartum period, rescreen for a return to substance use, screen for postpartum depression. That's one of the new guidelines as well. Encourage breastfeeding again, counsel on contraception and LARC again, because we don't want that unintended second pregnancy to happen. And then close follow-up. For these patients, there's ideally, well, actually the recommendation has already been made by ACOG, is to sort of follow a different postpartum schedule follow-up, or follow-up schedule. Not that traditional sort of 6 weeks, but to get them in 1, 2, 3 weeks later, and have sort of weekly visits through a 12-week period versus just like the 6-weeker and then you're off, because these patients need sort of more close follow-up. And the reason is because it's that high rate of death during that postpartum period for those with, substance use disorders. Those are some of the reasons why. So in summary, OUD in pregnancy, not uncommon. It is common. It's a chronic disease. There are effective treatments. So please encourage them, advise. Early identification is the first step. If we don't know who's using and who can need help, then we can't get them into treatments. Be aware of, prepare for, monitor appropriately, and treat NAS and NOWS. And then some of those special considerations for obstetric care. And please make sure that patients receive treatment in that postpartum year 1. And that's all. That's all I got.
Excellent. Thank you so much, Dr. Kamgar. Okay, well, I think we'll wrap up for the day then. We'll get those resources and references for you guys and share those at the next session, which will be on Wednesday, July 10th, same time, 12 to 1:30 Pacific time, same Zoom link, Zoom code to join. We'll be starting our curriculum over at that session with the basics of MAT, what it is, who it's for, those types of things. So we hope you'll join us then. Thank you so much, Dr. Kamgar. Thank you, everyone, for joining us today. Hope to see you in a few weeks.
Thanks, everyone.
All right, bye-bye.